Hello YouTubers, Joe Kersey here on February 13th, Thursday, 2014 at, it's around 2:30 in the afternoon, quarter to 3 in the afternoon Eastern time. That's 28 degrees Fahrenheit. That's just magnificent, isn't it? What a heat wave. We'll give you a fast look at the creek bank here, and then said he, without having forgotten to, haven't zoomed back yet, have I? So we'll zoom out a bit here. So here we are, here this fine day, and I'll give you a good look at the sycamores. The sycamores are turning white again. The sycamores are turning white again, which, you know, the dark bark had been creeping up, and now it seems to be, at first I thought it was being attacked by woodpeckers, but I think it must go through some sort of renewal process. Wish I knew more about that. Well, we'll get a little more shot out there. Well, now that I'm in wide angle, I imagine you can see me more than my, whatever you were able to see. I better be sure. I gotta get this storm door clear. I got tired of, Merle would have said, sitting on my dead ass, and decided to decided to finally turn off this device and get up and move around a bit, and went out on the porch for about half an hour or so and just admired the situation and the day, and then I went down to the mailbox to see if we were going to get any mail. Now, I noticed this morning when I took the trash down that the mail carrier had indeed made a pass through my shoveled out area, but didn't leave anything, and it's really too early for them to show up today, so when Paul gets home, maybe he'll find some mail in the box, who knows. But again, you know, sort of like a moth to the flame, I want to tell you a few stories. You'll notice, first of all, that I look back among the land of the living a little bit more. When I went down and took the trash out this morning, I smelled spring in the air. So I came in and got the actual buzz clippers that we use to do trimming and hair cutting on ourselves, and took off all the attachments. You know, I just did this with the they have, like, 1, 2, 3, 4 little things you can put on the thing to control how short it gets cut. I just use this with down right against the metal, and that got it down to sort of this sort of 3-day Arafat type look that I guess is very metrosexual nowadays. But what it did was it got it short enough that I could shave it off without having to run through about 2 or 3 disposable razors. So, mission accomplished. I was going to do some errandy, running around, doing some stuff today, and that sort of fell through, and so then I ended up just being a worthless load. But it was kind of fun. So, see, my definition of wasted time is doing something that you don't have to do, that you don't want to do. Now, today's category fell into doing something I don't have to do, but it turns out I sort of wanted to do it anyway. So, there. But that means it didn't fall into my definition of a wasted time. I want to tell you a little story from couple stories from anesthesia training. There were 11 staff anesthesiologists at Ohio State that were, that trained me, and they each one of them, in their own way, contributed something to how I ultimately ended up doing anesthesia. And while they all sort of basically did things more or less the same, well, not the same way, the strategic approach was the same. Their tactical way of going about implementing it they were all very different. So if you were doing a case with one guy, he might want you to give a drug a certain way, or not give a drug at the end a certain way. I mean, they're all, the job got done and the patients were taken care of, and nothing was dangerous. It was just different ways of doing things. And sort of toured after I'd been doing the anesthesia residency for 18 months. So I did a year of surgery, then I did two years of anesthesia, but the 18-month mark, around late November, early December of 1974, because I was 1977, because I was going to finish in June of 78. This one guy took me aside, and this was a fellow that I just, I got along with all these guys, but I didn't get along with this guy. I mean, I got along with all these guys except this guy. And sometimes just going along with somebody. I mean, I generally got along with pretty much all physicians I dealt with, but there were probably about 5 over the course of my career, 6 possibly. But I liked them. I just couldn't get along with them, and they couldn't get along with me. Some of these guys. I mean, I think some of the guys that couldn't get along with me, they just didn't like me. So this guy said, and it made a great deal of sense. He said, I noticed when you start a case, you never do it the same way. And I said, well, that's because everybody sort of does it a different way around here, and I never quite know. He says, you have to figure out what you like to do, and then start doing everything the same way each time. So figure out what you like to do and can get yourself out of trouble with, and then do it the same way each time. That was one of the most valuable things ever pointed out to me. I mean, and it's so blindingly obvious. It's so blindingly obvious. So figure out what you can do and like to do, and that you can do without getting yourself in trouble, or if it does get you in trouble, you can get yourself out of trouble, and then do it the same way each time. each time. In other words, set up your back stand the same way each time. Set up your machine the same way each time. Put the drugs on your machine the same way each time. Hang your IVs the same way each time. Tape in your IV the same way each time. Tape in your tube the same way each time. So that when something unanticipated happens, or then you know what has been controlled. You know what is normative. And then all you have to do is look for the oddball thing, rather than wondering, well, what's happening today? Now, it turned out the way he wanted me to set my back stand wasn't the way I like to do it. And he gritted his teeth and went along with it. And there was one guy that, he tried come hell or high water, he wanted me to sit down while I intubated. And I said, I can't do that. And when I say I can't do that, I meant I can't do that. It wasn't like I didn't like to. It's like I couldn't see. I couldn't see. If you can't see the hole, you can't stick something in it. Let me reiterate that. If you can't see the hole, you can't stick something in it. And then I'm going to sort of add dash consistently and safely. Because we all know that sometimes you can, but that's not the kind of hole we're talking about here, guys. Well, actually, it is in a way, because sometimes, as I talked about in an earlier video, sometimes you just have to stick the tube where the bubbles are coming in. That would be interesting in another context, and stick the tube where the bubbles are coming out. That might get kind of filthy. Well, leaving aside that innuendo, today's, and with that preludial material out of the way, let me talk about, I won't use this man's name because I think he's still alive. I sure hope he is. I'm going to call him Dr. P. And I decided that if I was going to adopt an individual's or try to pattern myself after somebody on the staff, it was going to be Dr. P. And well, we'll just tell a few stories here. Well, before we tell the stories, along about April of 1978, the chairman of the department, Dr. Hamelberg, took me aside and said, we've all decided that if you want to stay here next year on faculty as an assistant professor, you can do that. You can do that. And the assistant chairman, Dr. Bernard DeLeo, said yes. He says, and we made sure to get you an appointment as an assistant professor rather than just an instructor, because that way, if you ever go anywhere else, they'll have to take you on at that academic rank. And I said, that's great. So knowing in early April of '78 I was going to be on the faculty, I thought I've got to basically learn how to I've got to learn everything I can learn from this man. And so essentially, at that point, I was senior enough that they let me sort of pick and choose my cases. And I basically just chose any room Dr. P was going to be staffing, because I wanted to learn everything I could from this man. And one day, we were doing a whole sort of a 10, 11, 12 patient list of rigid esophagoscopies and rigid bronchoscopies. Now, this was before the era of fiber optic this and fiber optic that. They were just starting to come in. but they were very big and clumsy, and people weren't adept with them because they hadn't been trained with them. So they had to learn using them. But the old rigid bronchs and esophagoscopies, it was basically these long stainless steel tubes that you stuck down bronchuses and esophagus. And there was a classic book written on how to do that by a fellow named Jackson. And these things are relatively short cases. And here it's with the rigid scope. There's always a problem. You've got two people competing for the airway, the surgeon and the anesthesiologist. And if you pre-oxygenate somebody for 7 or 8 or even 12 minutes, especially if you go out to 12 minutes, you can basically have them stop breathing for 3 minutes before their oxygen concentration drops to the point of, because you've saturated their tissues, and so it comes out of the tissues and it keeps their oxygen level. But so you've got about 3 minutes, possibly 3.5 minutes of complete apneic time. So you can paralyze somebody, with succinylcholine. Well, you can use something even shorter acting now, but and ventilate. You get their carbon dioxide level down and their oxygen level way up, and then you kick that table, you unlock that table, you kick that around to the surgeon. He's got 3 minutes to work. And they're instrumenting things and looking, and then after 3 minutes, the guy pulls out, turns the table back around, you ventilate some more, and then he gets another 3.5 minute whack at things. And there's another technique too that you can use that involves curare. I don't know if I doubt they still do this. But it's essentially you sort of partially paralyze them so the guy's breathing while the guy's working, and he's underventilating, but it buys them a lot more. You can generally buy them about a 20 to 30 minute window of working time that way. Particularly if you're blowing oxygen down the side of the rigid scale. And you might end up with a PCO2 of around 70, but their head's home, and as long as they're not doing anything, it's absolutely critical that they can't have slight movement of the field. And a good guy, can do that. So I learned various endoscopic techniques from this guy. But he came in one morning and he says, "Today I'm going to show you how to give Valium by the clock and fentanyl by the clock." Well, the thing about Valium is, in the absence of any narcotics and alcohol, the thing about Valium is, that's diazepam. In the absence of any narcotics or alcohol, it is one of the most profoundly safe drugs out there. You cannot render somebody apneic except at the most extreme, we're talking 300 some milligram dosages, levels of drugs. You cannot, and then they'll probably seize from the diluent rather than the drug. Well, because the drug prevents seizures. Well, except the diluent overrides that. Well, anyway, without getting into the extremities of pharmacological therapeutics here, or dystherapeutics more accurately. I'm going to show you how. So essentially, he walked in, he says, "Now we're going to give this Valium by the clock," and a syringe full of 10 milligrams of Valium. Well, that's And he says, now we're going to go by the clock. And so he says, now see, you look over by the clock, look at the clock, and just whoosh, just push the whole thing. Well, you know, as somebody who had worked with, you know, all these other guys were, you know, see, the great thing about Dr. P was he taught me that it's in what drug you use. It isn't what dose you use necessarily. It's how you give it. It's not the drug, it's not the dose, it's how you give the drug. Because that, you can make a lot of drugs do a lot of things that they aren't designed to do, depending on how you give them. Particularly if you give them very rapidly. You won't read about that in the package insert, but that's the way it's done, guys. You won't read about that in the chart either if you're careful. Phew, and then he says, now I'm going to show you how to give fentanyl by the clock. Well, you can see what's coming now. 10 cc's of fentanyl. Well, fentanyl, for those of you who don't know, is a synthetic narcotic of the piperidine class, and you know, it's of the same class as Demerol, which is also a synthetic narcotic, which actually started out to be a synthetic atropine. Now, unlike Demerol, which is a horrible drug, piperidine, a horrible drug. You know, don't give it to your chickens. It's a horrible drug. Fentanyl is a very good drug. It's very potent. It's relatively short-acting for a narcotic in the sense that, again, depending on how you give it, it's more or less, its major effect is going to be pretty much over within anywhere between an hour and a half and 3 hours, depending on how the individual person responds to it. And yeah, and it's easily reversible. Well, a lot of narcotics are easily reversible. So, but it doesn't tend to come right back on you. Well, it depends. If you've given a lot of it, it might come back on you. It might sort of recirculate out and come back on you and re-narcotize you. So again, it's how you give it. And so what this guy did, see, and I thought, well, now we're going to shoot in the muscle relaxant so this guy can do this esophagoscopy. I think he's doing both, bronch and esophagoscopy. And this guy's just apneic. I mean, this guy's flaccid. And I started to take the blood pressure, and Prince says, Dr. P says, don't take the blood pressure. Just don't take that. Don't pay attention to that. Because when you give anything else on top of Valium like that, you know, I mean, it just, you know, there's going to be a period there where there ain't going to be any blood pressure that's worth trying to find. So obviously you've got to sort of choose the people you do this to. I mean, you can't go into, you know, you can't go into an 80-year-old guy who's had, like, you know, 5 MIs, you know, and no coronary revascularization and do that to him, because that would kill him. I mean, you can't. But you know, you can go into a 45-year-old guy that basically hasn't given you any cardiac symptoms and do it. Yeah. So I mean, it's how, you got to choose who you do this stuff to. I mean, you don't do it to everybody. You got to use your brain. So that taught me a lot. And then that's sort of like the middle part. Now, right now, sort of this next story comes from pretty much late May, perhaps even early June of my final year. You know, just before I was going to be going on the faculty in 2 or 3 weeks. I don't know. Hell, it may have actually come from late April. But we had a fellow come in with a ruptured aneurysm. And he's lying there on the cart. And, he's pale and gray and sweating, and blood pressure's 90 if it's that. And good luck finding a vein. This guy's almost in cardiovascular collapse, and Dr. Prince and Dr. P and I were doing this case. This was in the evening. This was like 8 or 9 at night, and he says, you're going to take one arm, and I'm going to take the other arm. We're going to get 2 14-gauge lines in this guy. And he says, you only get one chance at this. I said, what about an internal jug? He says, we'll put that in the room. After. But first, we got to get these 2 lines. And internal jug being an internal jugular cavity. Done with the posterior approach, not the fancy anterior thing that is very common nowadays. This was a quick and dirty bang right in the back, right down in. You rarely ever hit the lung, and you rarely ever hit the carotid doing that. And so got these 2 14-gauge lines in, and then Prince says, "Where's the?" I'm sorry, Dr. P says, "Where's the fentanyl?" Well, I'd learned to walk around with a pocket full of these things, because you never knew, what you might happen upon in the hall. You might have to put a fire out or something with some drugs. They kept walking around. And I said, "Here," he says, now I'm going to show you how to do a ruptured aneurysm." And I said, "Do you want to take him in the room first?" He says, "That just upset people." Well, this guy, first of all, if you have a ruptured aneurysm, you're going to be dead anyway. Untreated, you're going to die. Period. So there's nothing to lose at this point. This guy was ruptured. This wasn't a leaking aneurysm. This was a free rupture into the abdomen. He's basically, any blood he's got inside him is in his abdomen. It ain't in his blood vessels at this point. So, first you got to be humane. Second, then you got to get ready for them to wheel him in there and lay the knife on the guy, because when they wheel him in there, they're just going to throw betadine over him, and they're going to lay a knife into him. And meanwhile, we're going to be intubating him and ventilating him and getting another line in and start pumping, any fluid we can get our hands on into it, along with blood, as fast as they could bring it up from the downstairs. But that taught me the approach about, if you've got somebody who's going to die, that taught me, if you've got somebody who's going to die, just go ahead and do what you have to do, even though it might sound like it's going to make him die faster. As long as the goal is obviously to take care of the guy. I may not have made that clear at the start of this. And then one final story, and this comes from very early in my training, and this epitomized to me why I wanted to follow him around. I'm going to get a little teary on this one, guys. We had nominally, our operating room had 14 operating rooms at Ohio State there. In reality, we had 11 operating rooms. 12. But we had two smaller operating rooms. One was a urology room where they did a lot of cystoscopes and TURs, and my word, they didn't use much electricity in there because they kept the lights out the whole time. And then we had this room that was actually built out of a converted janitor's closet. And by room, I'm using that word advisedly. This room actually didn't have but one light, and I used that word advisedly as well. And what it was for they did it for D&Cs. They'd use it for D&C folks. You know, somebody came in with a miscarriage that needed to be completed, or they were just having dysfunctional periods, or you know, for whatever reason, the woman needs a D&C. That until a good uterine cry was obtained, and then we all went to recovery. That was sort of how the dictations ended on those cases. And we had a very large woman come in for one of these. You know, she sort of hung over each edge of, I'm not going to say it was the table because it was a cart. You know, they just wheeled the cart in, and then, so that meant you as an anesthesiologist had to stand up sort of on your knees, you know, to do the case, or, you know, or on a series of stools, you know. And I'm a short guy, and I like to look down at somebody when I'm working on them. And so I had my set of 5 stools there, you know. And this was a woman, like a lot of these women that hang off each side of the cart. She also had certain, how should we say, problems with her airway. A lot of soft tissue impingement on her upper airway, even though her anatomy was more or less normal. It wasn't like she was, you know, orthognathic, you know, or sort of, you know, one of these, you know, sort of, she had really normal anatomy, but it was hard to see it, you know, because she was very, very soft tissue laid. So she also was, let's just say, it was hard to evaluate whether she was oxygenated by looking at her color. It wouldn't have been easy to see pink on this woman, or red, you know, like well oxygenated. So I said to Dr. P, I said, "Oh, you know, we're going to tube her, certainly." He said, "Ah, you don't need a tuber. You don't need a tuber. You don't need a tuber." Okay. Well, of course, I've always had a tube ready. Well, a selection of tubes ready. And I always had my succinylcholine ready. Well, because you do. I mean, you do that for anybody, regardless of what anybody says. So, you know, he says, just mask her, you know, it'll be fine. Okay. Well, see, this is before I really knew this is before I knew how this man really taught people. Or more accurately, taught me. Because I was like 2 months into my anesthesia residency after a year of surgery. And so, you know, put her to sleep, ventilating her. I mean, she wasn't all that hard to ventilate. But the problem is, you know, if you're not, see, muscle relaxants can get you, if somebody gets stimulated, if you put a clamp on their cervix, and then pull that, particularly the pulling down part, that puts a lot of people, a lot of folks into bronchospasm. Well, not bronchospasm, but laryngospasm. Particularly if they've got a lot of secretions going on. He didn't want me to give her any atropine. Well, we didn't have glycopyranol then. We just had atropine to dry up the secretion. So you're blowing the snot down on the vocal cords, and of course it goes boop. And they say, oh, just apply gentle positive pressure and then they'll open. That's bullshit. That isn't what happens. They stay closed until the person becomes hypoxic and takes that last gasp, that which I have talked about in a previous video. So, about, a couple, 3 minutes into the case, that's exactly what happened that I've described, and it's like you're squeezing the bag. It's like you're banging your head against this table. That's what it's like squeezing that bag. And I thought, I'm going to smother this woman. If I don't do something, I'm going to smother this woman. And so I paralyzed her and intubated her. Then later, case went over. She started breathing after the sucks wore off. Pulled the tube out. It was fun. Then Dr. P, actually, Dr. P didn't come into the room. He wandered down to the recovery room though afterwards. And he says, "Oh, how'd that case go?" How'd that case go? I said, "Well, she laryngospasmed, and so I paralyzed her and put a tube in and ventilated her." He says, "Yeah, I know." He says, "Yeah, I know." Since I was out there watching the whole time. See, he was watching through the window and the door, but because of the angle of things and sort of the intensity of my focus, I didn't notice him out there. He was watching the whole time. He knew he wasn't going to let me get in trouble. He wasn't going to let me kill this woman. So yeah, I just wanted to see how you'd respond. And I'm going to tell you one more story. It's not on this list, but it just occurred to me. This was later. This was toward the end. This was in either early June or late May of. Oh, I don't know. It was anything after April of '78. As far as I was concerned, I was on the faculty. I wasn't teaching anybody, but they trusted me like I was on the faculty. And I was on call, which meant you had to stay there that night. And Dr. P was on call with me as the staff man, and toward the end of the very late afternoon, early evening, we finished up all the add-on cases. He said, "Well, I'm going to go home now." Well, that's kind of a bit unusual because, a lot of times he'd stay in the hospital overnight. He said, "I'm just going to go home. I'm going to go home now." And he says, "You got my phone number?" I said, "Yeah." And he says, "You always call me if anything comes in that, I said, "Yeah." He says, "You don't need to call me, though." See, I told you I'd tear up sometime. So on that note, bye-bye, YouTubers.